is for us the most important beta cell function test, the beta cell insulin secretion test. As you can see, no matter what is the weight, the performance was the same. Again, nothing to do with preoperative BMI. As you can see, there was a statistical significant increase or improvement in beta cell glucose sensitivity, although we were not able to normalize this function in relation to a normal population. The other important measurement or beta cell function test was rate sensitivity. I will explain to you the importance of so many beta cell function tests tomorrow and how important are they in relation to patients' selection. Again, a sharp and statistical increase or improvement in rate sensitivity in relation to preoperative, no matter what type of stimulus. Here glucose and here a rapid immune. And also the potentiation factor. We all know that insulin secretion is time dependent, and potentiation has to do with time and also has to do with other stimulus, like for example GLP-1. And so the potentiation factor has a lot to do with the GLP-1. As you can see in red is the typical stable and flat type of performance of the potentiation factor pre-op, and the sharp increase of the potentiation factor post-op, probably closely related to GLP-1. And I will also like to call your special attention to this graphic, to this table. As you can see here, in relation to fasting insulin, no matter if the patient is normal weight, overweight, or obese class 1, there is a statistical and significant decrease of fasting insulin secretion rate post-op. That was predictable. What was not predictable was the finding of the total insulin output. Take a look at that. On the lean patient, usually they have very few amount of insulin. Take a look at what they get. The patients that have less insulin pre-op are the ones that get more post-op. Patients like the obese patients that have a lot of insulin pre-operative period has in the post-operative period almost the same amount of insulin. That means that the operation was able to tailor to the preoperative amount of insulin on the specific patient. By using Kleppel-Meyer type of curve, we were impressed with this finding. This has to do with insulin sensitivity. In red, low insulin sensitivity, which means very insulin resistant patients. Middle in green or in blue, and high insulin sensitivity in green. That means that the least, or the patients with the least or the lower insulin sensitivity rates have the better performance. What was strange for us and really a surprise was that no matter the age, the duration of type 2 diabetes or obesity, no matter the three types of these variables, the results were the same. That means that insulin sensitivity, the preoperative insulin sensitivity, was the major or the most important predictor of success, but this has not to do with age, duration of diabetes, and obesity. And the same in relation to baseline BMI and to weight loss. As you can see, no matter the preoperative BMI, no matter the amount of weight loss, the result in terms of insulin sensitivity and possibility of cure of, or not cure, of control of type 2 diabetes was the same. The best that we could get was related to insulin sensitivity. Again, no matter the preoperative BMI, the result, or the postoperative result, was the same. As you can see, there was a complete normalization of insulin sensitivity in the postoperative. And this is another work that we recently published in the endocrine reviews. As you can see, insulin sensitivity improved after the first year and has a very minor improvement after the second to the third year. But this was nearly the same, meaning that the insulin sensitivity, once we approach the first year of postoperative, will be the same in the long run. And this is also the same in terms of hepatic resistance and also in terms of muscular sensitivity. Take a look at the hepatic resistance. 1 year improvement, and that was almost the same. And almost the same in terms of muscular sensitivity. But that was not in relation to the insulin secretion. And that was the reason why I mentioned to you that insulin sensitivity is a problem that usually is being solved as soon as 1 month. Insulin secretion has a continuous improvement throughout the years, as shown in this work published in the endocrine review. Again, as you can see, there is a continuous improvement of insulin secretion throughout the years. Here, area under the curve of insulin glucose 0, 120, and area under the curve 0, 180. This is, at least for us, very important, that clearly mention or clearly demonstrate there is a continuous improvement of insulin secretion throughout the years. And also in relation to the disposition index, that is an index that combines not only insulin secretion and insulin sensitivity. So when we first realized that there is a very good improvement in insulin sensitivity and continuous improvement in insulin secretion, the product of these two indexes, that is the disposition index, should not be different of what we are seeing here. I would tell you, and this is a paper that we are preparing at this moment, that the disposition index is a very interesting and reliable marker of success of the operation. That means that we are shifting the curve from a typical preoperative type 2 diabetes to someone that is almost normal. Take a look at what we see on a normal patient. This is a typical normal glucose tolerant, impaired glucose metabolism, and type 2 diabetes. Take a look at what we are getting here with the operation at a 3-year evaluation. There is a shift, or right side, an upward shift of the curve that closely resemble or closely similar to what we've been seeing on the contrary. So patients usually, as they get diabetes, they have this type of curve, a left and downward movement of the curve. And that's what we are getting with the operation. This is something that is extremely important on our point of view. In relation to other tests, we have the euglycemic and the hyperglycemic clamps. The euglycemic clamp is the gold standard type of test to evaluate insulin sensitivity. Again, as you can see, a sharp and statistically significant increase of insulin sensitivity in relation to free fat mass, and also the insulin sensitivity index. There is a increase of the C-peptide secretion, as you can see here, with this paper that was published in the SORT. And this is as soon as 30 days. So there is also a secretion improvement as soon as 30 days. And that this has nothing to do with weight loss. This is the covariance analysis of the impact of weight loss in relation to insulin sensitivity. There is no correlation between the weight loss as early as 30 days and insulin sensitivity. And here, as you can see, the disposition index, upward and right side movement or shift of the curve as soon as 1 month. In terms of insulin clearance, this has to do with the liver hepatic resistance. There is a statistical significant increase. Again, by using the euglycemic clamp, an improvement in the insulin sensitivity during 2 different periods, and also an improvement of insulin secretion when evaluated by the euglycemic hyperinsulinemic clamp. This is another paper that we published in the Diabetes and has to do with evaluation of insulin sensitivity and secretion in type 2 diabetes evaluated by the euglycemic clamp. This was a paper that we performed the euglycemic hyperinsulinemic clamp later on in the follow-up. Again, a sharp improvement of the disposition index, better than the figures or the amount that we've been seeing in the 30 days. And again, this is the typical figure that we were able to get when we have preoperative euglycemic hyperinsulinemic clamp in rat 1 month, and later on post-operative 22 months in the post-operative period. I will also call your special attention in relation to the normal picture that we used to see in relation to the movement of the normal tolerant, glucose tolerant toward diabetes. So what we are doing is the opposite move. So as you can see, this is pre-op, 1 month, and later on, 22 months in the post-operative period. We are also dealing with first phase insulin secretion evaluated by the hyperglycemic clamp. There is an incremental increase of this first phase. This is extremely important. I will discuss this in detail tomorrow. And also in relation to the second phase. These are the 2 main aspects of the pathophysiology that we would like to address early on with this operation. As you can see, there is a sharp increase on the performance of the second phase in relation to the preoperative